Hello, I'm Dr. Randy Martin. I want to welcome you to this exciting roundtable we're going to have. You know, there are dramatic developments in mitral and tricuspid valve diagnosis and surgery. So here at EACTS 2017, we've assembled a fabulous, outstanding panel to discuss these developments. So let me introduce the panel. To my right is Professor Michael Borger. Michael, good to see you, head of cardiac surgery at Leipzig.
Thank you, Randy.
Good.
Nice to be here.
Good to have you here. David Adams, my friend from New York. David, you're chairman of the Department of Cardiothoracic Surgery at the Icahn School of Medicine at Mount Sinai, right?
Wow, that was a mouthful.
That's a lot.
Yeah,
That's a
wow.
lot. I got it all out. That's it. To my left is Vinay Bapat. I should call you, do I call you doctor or professor? Since you've changed now, you're in the United States, so you're now doctor.
It's Mr.
Mr. Okay.
My badge still said United Kingdom.
So Vinny is the assistant professor of surgery at Columbia University Medical Center. Michael, you know something about that, don't you?
A lot.
a lot. And then Professor Octavio Alfieri, professor is not only a professor but chairman of cardiac surgery and the director of cardiothoracic and vascular surgery in Milan. Glad to have you here. Good. Glad to have you here. So we're going to be talking about two topics. The first topic we're going to talk about is really where are we with the current surgical therapies of mitral and tricuspid disease. So let me ask the first question. New developments in guidelines, both in Europe and the United States. You think these developments are where we stand today, that patients are being, with either primary or secondary MR, are being referred to you in a timely fashion? So, and the referral patterns know what needs to be done? What do you think, Michael? Do you see this?
Yeah, I certainly, you know, we've all seen a trend towards earlier referrals in the patient disease process, more patients with asymptomatic disease with repairable pathologies. And I've seen this across in the United States and in Germany. I still think there's still room for improvement, particularly in some of the countries where the message has not gotten out as much as it has in the United States and Germany. And you still see the odd patient being referred too late, but I think referring physicians have gotten the message.
David, what do you think in New York?
I think the guidelines continue to emphasize early referral, and the updated guidelines put an exclamation point on that. And if you're trending toward trigger points, it's appropriate to refer patients. I still think lots of patients get referred late in the sense that even in advanced centers, many patients are in atrial fibrillation and many patients have ejection fractions below 60. So it's definitely changed a lot the last 5 years. I still think there are a lot of physicians that are still waiting for patients to develop symptoms to refer. So there's still a long way to go.
Vinny, what are your thoughts?
I think on the mitral side, definitely there has been an improvement, but on the tricuspid side, I think there's a lot to learn. It's not uncommon to get a lot of tricuspid referrals with burnt out right ventricles.
Right, with bad RVs.
And this is where there's unclarity about when to refer, when to intervene, and this is where I think we need to improve.
Good.
On mitral side, it's not reached the level of awareness in aortic stenosis yet, but I think that's because of the whole TAVR revolution.
Correct.
So I think there's a long way to go.
Good.
Yeah, I think that early repair of the mitral valve certainly is a good thing. There are a lot of evidence in this regard. But early repair, in my opinion, is justified only if repair can be done successfully and if repair is durable. And there are complex cases where you need a particular experience and expertise. So these are the conditions for early repair in asymptomatic patients. Otherwise, maybe it's better to wait a little bit longer.
So the knowledge is advancing, but we need to continue to push it along. What about in primary mitral regurg and valve repair? Okay, tremendous advances have been made. I think undoubtedly we could talk about the respect versus resect and the chordal therapies, but what about in the arena of annuloplasty, rings versus bands, radiopacity, if you're thinking about transcatheters down the line, the shape of those, do they need to be circular? Where do we stand with the whole annuloplasty arena? Professor, what do you think?
You know, we have to think that in degenerative mitral valve disease, the late problems are rather low. And for instance, the data that we have, they're telling us very clearly that significant mitral regurgitation occurs in about 10% of the patient in 20 years. So the rate of redo situation is rather low. So I don't think that radiopacity and complete ring should be in a degenerative mitral disease a primary concern. And as a matter of fact, we use flexible ring there and incomplete rings.
Okay. David, your thoughts? Because I know your approach has changed a little bit over the years, hasn't it?
Yeah, I mean, I think angioplasty is part of a repair strategy. So as you evolve toward leaving more tissue, that takes you sometimes to different types of angioplasty concepts. So we're using, for instance, much more bands right now than rings than we have in the past. We are also sensitive about stenosis with small rings, or functional stenosis, I should say. So if there are certain patients that we really try not to put a complete ring in if we can help it. So there's I think the paradigm shift, at least for us, has been based on increasing awareness and knowledge and publications in the literature from others describing certain complications with angioplasty systems. So that's one thing. I agree with Octavio completely. The valve-in-valve discussion, which is everywhere, is actually not going to be very common in degenerative disease. And the 10% failure rate that he mentioned is actually data from 10 and 15 years ago. I think we're much more sophisticated now in our sort of thought process about the depth of closure and not over-resecting tissue. So my prediction is that the reoperation or reintervention rate would be even lower in the future.
Michael?
It's interesting that David said that about switching more towards a band than a ring. And I presented yesterday's data from our center from Thilo Nowak, one of my colleagues, who's done 4D TEE on patients before and after surgery and normal controls compared to FMR and DMR patients. And two things that came out of that work is, one, that the intertrigonal distance is probably the most important measure to base our ring sizing on, because it does not vary if you compare it to normal patients or functional mitral regurgitation or degenerative mitral regurgitation. It only increases a very small amount. And the other thing that he demonstrated is that we're probably putting in too small of rings, and a band may be more appropriate. And certainly there's very good evidence from Toronto and from Mayo Clinic that these guys achieve good results with this strategy.
Yeah.
You were going to say something. Were you going to comment to that, or we can?
Oh, I was just going to say, I think what Michael just described is exactly what I think is the reason that you should think about different ring strategies. You shouldn't just get wedded to one ring or one shape anymore.
I think this is a very interesting conversation, because we're looking at it from viewpoint of world experts, but that's not really a day-to-day practice in majority surgeons' hands. So in Colombia, every Monday and every Wednesday, I get at least 2 or 3 referrals of failed repairs, and these are referred for valve in a ring. And this is where we are struggling at present, that do you want to implant a ring which can do the job, what you want it to do when you implant it, but at the same time make it compatible with TAVI devices, which is not a bad idea, and especially in secondary MR, because these are the patients in which we know that there is recurrence of MR, which is much higher than the primary repair.
Well, that's a different. I mean, I think it's a valid point. So he's saying that it does make a difference if you're thinking about primary, MR, DMR, and the ring or band selection.
Yeah, the issue with secondary MR failure, which will be much higher, it will not be 50%, but it will be, let's say, 20 or 25%. Lifetime for patients, is that the rings are small. So I'm not sure whether it's radio opaque or not. You're not going to, at this point, we don't have technology for
Does the shape
VR inside a size 26 ring.
and the shape of it that it has to assume, if you're saying that you might be, you know, injustifiably putting in more valve and rings, does the shape of the annuloplasty device, is that important?
I don't think the original shape matters really. What matters is, can it become circular later?
Okay.
And that's what really matters. And most of these procedures are done transeptally now in these patients. And I completely agree with David. I think if people are going to use 26, 28 rings, but if they can accommodate a 26 size valve, then why not? That's equal to a 29 size surgical valve.
So let's shift gears.
Well, let's
Go
just
ahead.
finish the discussion because this is interesting. You're talking about a Sapien 3 then, and that small ring. Yeah, so you're talking about an off-label use of a TAVR inside the ring.
It's valve-in-valve mitral is on label now. It's been approved. And the only reason I think the mitral ring may not be approved is because we have got 26 different types of rings doing the same job. So there's not enough clarity, despite 20 years of evidence, which ring is indicated in which way and which size in each pathology. I mean, there has to be some kind of science in this, and at present, I can understand in Barlow's disease you may, require a certain kind of ring, but a standard primary degenerative MR, there's still no clear. We shift every 10 years from complete to incomplete to semi-rigid to rigid. So what I'm trying to say is that this is going to change again 10 years later. So
Michael.
But you, as you know, Vinny, the results of the transcatheter mitral valve in-ring procedures has not been good.
Absolutely.
And do you think that a change in our strategy now, thinking that maybe the patient may come back for a transcatheter, can affect those results? Is there light at the end of the tunnel for this procedure?
Unlike the valve-in-valve results in mitral, the valve-in-ring results are bad because all rings are put in one basket. So these are rigid rings as well as semi-rigid, as well as some incomplete bands. And that's the reason the results are poor. And it's not because maybe the procedure is bad, it's because the Sapien is not circular in the end. So I think the whole philosophy is, can we take advantage of the technology in future to make the second procedure easier?
Yeah, I just want to challenge you a little bit more. Let's don't talk about how can we plan for all the failed valve repairs so we can then do valve and valve. I know that's your bias, but I'd rather say, how do we select appropriate patients for repair that will last and do valve replacement as a primary strategy in the other one? So I think that, yeah, it's an interesting thing, and I always hear industry all getting excited about valve and valve, and that everyone can have valve and valve, valve and valve, and then another valve and valve. But the reality is we should be trying, our goal should be to do a long-lasting operation the first time. And these patients have a limited life expectancy, so we should be able to accomplish
we got
that.
Other topics we got to get to. Let me hear from the professor. And then we can
certainly, we don't have to plan the operation in the perspective of the failure of the operation. Actually, we have to plan the operation
for
in
success,
order to have
not
success.
For failure.
No, but
actually, the data that we have up to now, they show there's really no difference with one ring and another, or a very minor difference. So this is the reason why there are so many rings around, and of course, there are no precise direction.
No, but my challenge to all of you is the main repair is not based on annuloplasty in primary. Your repair is based on leaflet and chordae. Annuloplasty is there to support the whole system. So why not make a ring which is maybe suitable for it in future? I mean, there's nothing wrong in it. Yeah. We are thought of.
You got 20 seconds.
I'm gonna try one more. Yeah, I'm gonna try one more time. Vinny, if you're getting referred 3 patients a week with failed degenerative repair, that's an indictment of the system. Wherever those patients are being done. And coming, I think that you're seeing lots of them because you're obviously the biggest transcatheter center in the Northeast. So this is a super specialized referral pattern. But having said that, I mean, I just can't accept that 2 or 3 degenerative repairs a week should get valve and valve in one institution. That sounds like a failure of the primary operation and operators.
And also, if you have a failure, I don't think that the best solution would be valve in ring. you can re-repair.
It's valve it's re-repair
right.
in degenerative disease.
Okay.
Vinny, you ooze in this discussion so far, but you made valid points. Let's move to a less controversial area, and that's surgical mitral valve replacement. Where are we today? Who do we do it in? Is there still an issue with mechanical versus tissue prosthesis? Michael, where are we?
You said less controversial.
Yeah,
Okay.
yeah, right.
Well, David summed it up perfectly well, is we have to identify the patients where a repair is not going to be durable and avoid a repair in those patients. So as Steve Bowling likes to say, a good repair trumps a replacement, which trumps a bad repair. And therefore, those patients where we think that we cannot get a durable result should
So who are those patients? Are you talking about in primary and secondary, obviously?
Well, secondary, the ones with the big ventricles and also the ones with the inferior basal aneurysm, those are very bad markers of recurrence, and they should be replaced. For degenerative, David would argue that you can repair all degenerative valves, and I would say that there should be some centralization, which is more prominent in Europe than it is in America, and that if you think that this is a pathology that's beyond your repair capabilities, you should be referring to a super specialized center of referral.
Yeah, I think that nowadays mitral valve replacement should be referred to patients, for instance, in rheumatic disease, that is an organic disease, sometimes with the calcification of the leaflets, so very difficult to repair. And in another situation, for instance, the post-radiation mitral regurgitation, with a lot of fibrosis and retraction of the leaflets, that is another area where valve replacement can be needed. In addition, for functional mitral regurgitation, now we have this CTSNet study showing that replacement in the majority of patients can be preferable to repair. But now also we can identify very well patients with functional mitral regurgitation who are likely to benefit from the repair and have a successful
Michael outlined.
And once you identify those, I think that repair should be done in those cases, because it's been very well shown that reverse remodeling is better with repair than replacement.
Vinny, what are your thoughts?
I think there are situations, we talk just of mitral pathology, but I think there are times here to look at the patient as a whole as well. In an elderly patient, at times in inexperienced hands, quicker operation is better than a longer complex repair, which fails, and then the surgeon has to replace. So there's sometimes you have to, if it's a double valve procedure or double valve procedure with grafts, and I think if you are unsure whether you can do a good repair or it's a complex pathology, I think it's fair to replace the valve.
Okay, good deal. David?
I agree.
Mitral valve replacement? Can I hear that coming out of your mouth?
Yeah. No, I think all the points are good. I think number one is Michael said, first of all, the failure rate of ischemic repair in the network trial was over 50% at 2 years, which is entirely too high. And I don't believe that number. I think the number, as I said before, is closer to 20%, and experts 10, 15, 20%. So the key for all of us is figuring out which one of those 15 or 20% not to do. If you're going to do those, it requires adjunctive techniques such as chordal cutting, something Michael actually reported first, cleft closure, and sometimes even a replacement of primary chords or augmentation. So there are different things that really advanced centers could do, but for the vast majority of patients and surgeons and centers, valve replacement in that population is appropriate. Octavio mentioned inflammatory valve disease. Be very cautious when you treat inflammatory valve disease, because you can correct the regurgitation in a fairly simple manner. It's very hard to prevent stenosis. The leaflets continue to get thick. And stenosis by far is the most common mode of failure. So don't be satisfied just that you've stopped the systolic flow into the atrium. It's really diastolic flow in the ventricle that gets these patients in trouble. And Vinny's comment about a complex operation is probably the most controversial one. Sometimes I get referred patients and the cardiologist says, this patient's 80, I just want a quick replacement. But that data actually doesn't hold true in the modern era of cardioplegia. I think that if a patient has a repairable valve and the surgeon's capable of repairing it, they should probably try it because the survival probably still going to be better. And you're right. If you're, I feel much less strongly about that in elderly people that have class 1 indications than I do in younger patients that have class 2A indications. What we have to be careful about is the young patient that needs a double valve and they're 61 and, oh, let's just do something quick. So I think there is a judgment there. The other group I'll mention, add on to, is mitral annular calcification. I think this is the subgroup we're seeing much more of when you talk about referral. Most of these patients weren't sent before. I think confidence in surgical centers now and surgical outcomes is leading to a plethora of these 80-year-old patients that have mitral annular calcification as a component of their either type 1 or type 2 dysfunction. And this is a very complex group. We have really struggled trying to repair almost all of them. And I must say, sometimes you're just better off folding the leaflets up and trying to do a replacement in the leaflet. Because these patients have a high recurrence rate.
Going back to functional mitral regurgitation, now, don't you think that maybe the percentage of patients suitable for repair can be expanded using something more than the annuloplasty, and to do something on the subvalvular apparatus, for instance?
Can I comment on that? I saw recently a really promising technique is from Evaldis Godalskis and Hermann Reichenspooner from Hamburg, and we're actually going to do a multi-center registry in Germany, hopefully a trial, where it is a sort of a take on the ring and string or the Irving Kron's procedure, but it's they've made it much more reproducible in that you put a heavy Gore-Tex suture through both papillary muscles, then through the annulus, tie the ring into place, pass it through the ring, and then under visual confirmations, you can actually see, as you're tying that Gore-Tex suture, you can see the posterior leaflet come up.
Exactly.
So the severe restriction.
The standardization, I think, is a big problem because, you know, for instance, there are Japanese surgeons who do, in 80% of the cases, repair in a functional mitral regurgitation, just acting the papillary muscles. And, but of course, this is not well standardized up to now. It's so much dependent on the experience and expertise of the single surgeon.
Well, I think this is a standardizable procedure, but I'll have to convince you with time.
But Michael, the thing is going to be, what are you doing that for? In other words, this thing I struggle with when I read papers about these techniques is it done prophylactically? In other words, would the patient have been fine without it? Or is it done because a primary cleft closure chordal cutting downsized ring wouldn't work until you lifted the papillary muscles? And so if it's going to be sort of a belts and suspenders, do it and all, and then look at recurrence rates, that one I could understand better than the sort of murky selectivity about who to do it in.
It's going to be a do it in all approach, and then hopefully a randomized study. First of all, a registry and then a randomized study.
But I think this is going to depend really heavily on remodeling, and which is something we can't predict at present, because if the ventricle continues to dilate, it's going to tether the, I think, and this has been one of the flaws of these different techniques of even, you know, getting the papillary muscle higher up.
Let's going down the line of controversial topics. What about the tricuspid valve? When do you do tricuspid repair? Do you do it with every mitral you're doing? When do you do it if the patient's referred to you late with severe TR and a bad RV? So what's the status? Michael, you're smiling. So
I've been, you know, pretty well convinced by David and Gilles Dreyfus's arguments that we should be more aggressive with tricuspid valve repair when there's annular dilatation, even in the absence of significant TR. Having said that, I do all my isolated mitral valves minimally invasively, and it does add a significant amount of cardiopulmonary bypass time, and therefore on the borderline cases I'll be a little more reluctant to do it than I would through a sternotomy.
So the approach dictates that, is what you're telling me.
It's a part of the decision process. If there's clear, you know, moderate TR, or if the annulus is 45 millimeters, of course. Yeah. But if the annulus is, you know, 39, 40 millimeters and there's no TR, and I'm doing it through a right mini thoracotomy, I'll say, you know what, I'll leave this one alone.
Vinny, and I'll come back to you.
I think moderate TR and severe TR are quite accepted now, that we shouldn't leave them behind when we're operating, especially on the left side or doing anything else. This is the mainly moderate TRs were left behind. And I think these are the ones we are correcting. Now the argument is, of course, whether minimally invasive, you should leave moderate TR behind. And I think a lot of surgeons probably still do that.
And any history of AFib, would you do it in those?
But you don't do any surgery prophylactically without any scientific proof. And I think in TR, without annular dilatation, or if it's only mild TR, I don't think there's any evidence at all to repair this and remodel this annuli in anticipation.
Yeah, the guidelines really are strongly suggesting to repair the tricuspid valve if the annulus is dilated, even with mild, moderate tricuspid regurgitation. And that, I think, is something that I usually accept very well. It's really adding not too much to the operation. There's another scenario totally different from tricuspid regurgitation, is the isolated tricuspid regurgitation, which occurs late after left side valve surgery. This is a totally different scenario where the patient is extremely symptomatic, presents with ascites, fluid retention, and right ventricular failure, pulmonary hypertension. Those are really very, very tough cases. It's a totally different scenario.
So I'll come back to that in a second. We're going to run out of time, but David, you've as Michael pointed out, your colleagues have looked at this extensively at Mount Sinai.
Yeah, we adopted a very aggressive approach based on the guidelines several years ago, really addressing tricuspid dilatation as an indication for repair or an annuloplasty in addition to tricuspid dysfunction. And when we look at our experience with that, you know, we did not see an increase in pacemaker rate, obviously not in mortality. And in fact, when we look, you know, we were selecting patients to not get a tricuspid ring during that decade. You basically had to have a completely normal tricuspid valve in terms of dimension and function and no AF and no pulmonary hypertension. You had a normal tricuspid valve and normal right ventricle. Everyone else, based on guidelines, went into a aggressive repair strategy. And when we looked, and this data was published in the Journal of the American College of Cardiology, what we found was no difference in the morbidity, but in fact, patients that had an aggressive tricuspid strategy had reverse remodeling of right ventricular dilatation and dysfunction, pulmonary artery pressures that came back to normal compared to patients that were completely normal to begin with, and the absence of the development of recurrent TR. So that was the basis for us feeling okay that we were following these guidelines. Now, there's a lot of controversy out there, and as you know, the Mayo Clinic and my good friend Tyrone at Toronto General continue to argue this point. But I think as a worldwide strategy, I think there is a move toward more aggressive annuloplasty. And the thing that you can't say in a publication scientifically, but we certainly see clinically every day, is when you eliminate perioperative TR, which you do with that kind of strategy, those patients that you struggle with tend to just be easier to manage. You know, TR, even acute TR that resolves, is a bad actor in the intensive care unit in sick patients. It does lower, it gives you, makes your hepatorenal syndrome a little, puts it under a little more pressure. And we just always feel good knowing we're not going to have perioperative TR with that. I think Michael's point needs to be called out. Again, Leipzig continues the tradition of being completely honest, which is refreshing in this business, meaning you're right, there are certain approaches where getting to the tricuspid valve would make you less inclined to do a 2A or 2B indication for repair. Because again, you're trying to balance the incision and the patient's wishes versus adding something that will be much more complicated. And as Octavio said from the front, it's a 10-minute exercise. So for experienced people, it really doesn't add anything. So there's still judgment, but I think that overall you're going to see more concomitant tricuspid repair.
Quickly, this is not a telethon.
We have to mention also the CTSNet trial, the randomized trial. So we'll have more data on this in the near.
So the problem, and we can't stop, Randy. Don't worry, we're going to get to it. Because here's the problem. because here's the problem. You say let's wait for the CTSNet trial, but what are they randomizing in the CTSNet trial? They're randomizing moderate TR along with angular dilatation. And what we need to do is understand what to do in angular dilatation, not what to do in moderate TR. So I'm afraid once again, this is going to be, hard to interpret and apply broadly because of this inclusion of moderate TR.
So David, if I read you correctly, just to summarize, I think that moderate TR, severe TR, definitely one should repair, and if there's annular dilatation, even without TR, you should repair.
So I think that I'll just review again.
This is,
you have pulmonary you have pulmonary. Randy, I know you want to talk about the future and things that are going to be 5 years from now, but this is taking care of patients today.
I understand.
you want to take care of moderate TR and severe TR. I think pulmonary hypertension is a big risk factor for recurrence of TR. Right ventricular dysfunction, large right ventricle, or low ejection fraction, as we've seen from the different Italian groups, is another marker, including Octavio. If you have ischemic MR, be very careful, because then you should be thinking more about the tricuspid, because the recurrence will be higher. And your paper showed that beautifully a few years ago. And I think also the presence of atrial fibrillation, even if you're treating it, because not every patient will be cured from it. Those are the patients I'd be aggressive in. For pure annular dilatation, that is much more controversial, and I think the data is much softer there.
Okay. Everybody agree with that? Proceed. Thank you very much.
You're welcome.
I've not heard that from you before, so that's good. so listen, we're gonna stop this section. Okay, I appreciate the thoughts, the controversy, because there is a lot of controversy.
Well, we didn't cover one thing, Randy. We have to cover, and that was Octavio's last point.
I guess we're not going to stop.
No, because we can't stop that discussion without talking for 1 minute about the timing of surgery for severe chronic TR. This is very important to tell everyone listening that this is a patient population you want to be very aggressive in and not wait till they are symptomatic. So if you see one, I would recommend you try and fix one. I'm curious what my
the problem. The cardiological community is not really referring this patient too much at the moment.
Absolutely. Well, they're in heart failure clinics.
Yeah,
and at the end, they send them to the heart failure surgery.
And then, of course, there's right ventricular failure, and you have pulmonary hypertension. That this can be a contraindication to surgery in those cases.
Okay.
Yeah, I will give you one tip we've seen. We do a lot of these. And our results have improved a lot since we have adopted a really minimalist approach. And what I mean by that is we do not put tapes on, which I historically did. We make sure we're constantly draining the right side and do all of them beating heart. If you've got moderate MR, or you've got atrial fibrillation, or you've got moderate AS, I'm not interested. I'm there to fix severe TR. I don't want to make you ischemic, and I don't want you to have any increase in your right ventricular venous system pressure the entire time. And since we've done that, I must say we have really eliminated the catastrophes that we used to always see when we got more greedy.
And another important point, I think, is the preoperative treatment of this patient. We put the patient in intensive care 1 or 2 days before, just to prepare them for surgery.
Yeah, preoptimization is so important in that population.
Okay. Can we take a break now?
Yes,
Is it okay?
If you're
you want to change places, but I don't know anything, so I can put you over here. But we want to thank you for joining us. We're going to be right back with talking about the future. I'm sure there's no controversy in the future, so come back and join us.